I welcome you all to the second day of our 7th annual AIMS ANTC conference. We'll now begin with our award paper session. To chair the session, we have Dr. Jogi, Dr. Ajay Sharma and Dr. Anna Teresa Mazzio as the chair people. We'll begin with our first speaker, Dr. Sangram Bal.
Good morning, everyone. For Dr. Joseph, everybody has to stick to time. It includes the discussion part, because that's part of our grading issues. The points we're supposed to look for is the presentation, the content, your confidence and delivery, and of course, the timing and making sure you handle the questions. We are not in a position to tell you about your time. There's a timer, please maintain. And whoever can set that back to 6 minutes, I appreciate it. Thank you so much. Start.
Good morning, myself Dr. Sangram, resident, Department of Neurosurgery, SS Medical College, Jaipur. It's not going. My paper, serum magnesium as a prognostic neurological marker in severe traumatic brain injury patients. As you now know, the traumatic brain injury is the leading cause of death in all age groups, and it contributes around 60% of death. It may be due to primary brain injury, which is induced by the mechanical force occurs at the time of injury, and the secondary brain injury, which is the impairment of cerebral blood flow, may be due to edema, hemorrhage, or increased ICP. Then coming to secondary injury, there is multiple biochemical and physiological pathways that get activated due to traumatic brain injury, which leads to the imbalance of the pathways that leads to the secondary injury to the neurons. And it may be due to hypotension, hypercardia, hypoxemia, or hyponatremia, or hypomagnesemia, or they may be due to infection. Then coming to serum magnesium is we know that it is the most important metabolite of the body, and it is transferred to the brain by mainly active transfer mechanism, and inhibits the excited neurotransmitter glutamate, and also blocks the MNP receptor, which leads to the calcium entry into the postsynaptic vesicles, and it also relaxes the vascular smooth muscles, leading to cerebral vasodilatation, and also it has a very important role in hemostatic regulation pathway that is involved in secondary phase injury. Overall, magnesium is as a neuroprotector. As you can see, magnesium, it maintains the homeostasis, protection of the blood-brain barrier integrity, and also blocks the MNP receptor, which leads to calcium entry into the postsynaptic vesicles, and also when the magnesium level becomes low in the body, there is release of substance P factors, which leads to increased probability of blood-brain barrier, and glial activation leads to increase of the various substances like nitric oxide, cytokines, prostaglandins, and which leads to neuroinflammation and neurodegeneration. Then we conduct a study to find out the relationship between the serum ionic magnesium and the traumatic brain injury patient, and with the neurological outcome in severe traumatic brain injury patients. We conducted a prospective study from June 2021 to May 2022 in the Department of Neurosurgery, SS Medical College, Jaipur, where we include the adult patients with severe traumatic brain injury patients. Mainly age group we include the 18 to 80 years with GCS 3 to 8 in severe traumatic brain injury, and also we both include male and females, and also the most important inclusion criteria is admission time must be within the 24 hours of the injury. The structure questionnaire developed by the subject experts. Blood sample was collected for serum magnesium level assessment. Initial serum magnesium was assessed within the 24 hours of injury, 20 hours of admission, and patient is divided into two groups according to that. That is mainly a low serum magnesium group and also normal serum magnesium group. And we low serum magnesium group, those patients having serum magnesium, initial serum magnesium level was less than 1.6 milligram per deciliter, and normal serum magnesium level is more than 1.6 milligram per deciliter. And the patients are managed according to protocols like mechanical ventilation, urinary catheterization, anti-epileptics, and mental in case of cerebral edema, and surgical treatment if as per needed. Data was expressed in mainly mean and standard deviation, with proportion were compared in Science test and student test. To confirm our results, we used the multivariate analysis conducted with logistic regression. The significance level was kept at p-value less than 0.05, and we assessed. Our assessment was based on the Glasgow outcome score which was assessed at the end of 6 months. As we all know, the Glasgow outcome score is divided into five categories, and we divide into 2 categories like poor outcome and good outcome. Poor outcome we took into the 1, 2, 3, where 1 is the death, 2 is the persistent vegetative state, and 3 is the severe disability, and 4 and 5 is the good outcome, where 4 is the moderate disability, and 5 is the good recovery. We found that out of the total patients included in our study was the 84, out of which 59% are male and 25% are female, where mean age is the 50 with standard deviation of 15 years, and there are 2 out of which low serum magnesium was found in 32 patients, out of which the poor outcome found in 28% out of 32 patients, which is 87.5%, and which is significantly higher. On logistic regression, we saw that low serum magnesium has 6.593 times odds having poor outcomes, and also GCS having less than 5 in patients with 3.09 times odds having poor outcomes, whereas the age and the GCS are most statistically significant with the outcome of the patient. There is a paper published in the Asian Journal of Neurosurgery by Dr. Raghavendra et al. In the 2018, where we included the 72 patients, out of which 42 patients having low serum magnesium level, and at the time of evaluation on 6 months follow-up, 81% have patients with poor or neurologic outcome has low serum magnesium at the time of presentation. Another paper published in the MPTA journal, where genotype barrier are the 22 found that there is solid evidence suggesting the magnesium in the control in the neuroinflammation, retards neurodegeneration, and to conclude, low serum magnesium may be related to the initial stress response to the severe injury, that it may be as an independent prognostic marker in severe traumatic brain injury patients. Thank you.
Anna? Thank you very much. Is there any question from the auditorium?
Maybe I could ask, there could be, how did you look up, how did you ensure that the confounding factors have been taken care of? Because the extent of injury, the initial resuscitation, and the magnitude of injury, the GCS admission, all that would really have
So we include the patients after the initial resuscitation, and also we exclude the patients that those who are under alcohol intoxication or multiple comorbidities, or mainly exclusion criteria was the if the patient was admitted after the 24 hours of injury, then we exclude the patients.
Anybody else? Otherwise, Sangram, nice talk. I understood something, but I want to make sure I misunderstood, correctly understood. You said the GCS did not matter as much as the magnesium level in your 87.5% worse outcomes?
Sir, GCS also matters. GCS less than 5 having the poorer outcome, and in logistic regression, we saw that GCS less than 5, those patients who are admitted with GCS less than 5 have 3.09 times poor outcomes in the patients with GCS more than 5.
But 6 times the odds ratio for the
magnesium.
Okay. Thank you so much.
Thank you, sir.
Appreciate it.
Thank you.
We now call on the stage Dr. Arshi Joshi, and he will talk us to know the impact of coagulation profile, the arrangements, and their effects on the outcome of head injury patients, a prospective study. Please.
Good morning, teachers. Thank you, NTC, for providing this platform. Today I am presenting my paper on to know the impact of coagulation profile arrangement and their effect on the outcome of head injury patients. Introduction. Traumatic brain injury is one of the most important cause of death and long-term disability in young adults. Traumatic brain injury is also a significant factor behind the death in day 1 after trauma. And incidence of coagulopathy in traumatic brain injuries range from 10 to 97%. Coagulopathy leads to hemorrhagic lesion and increased chance of mortality. Factor affecting the traumatic brain injury includes release of tissue factors, disseminated intravascular coagulopathy, thrombocytopenia, and activation of protein C pathway. Aim of our study to know the impact of coagulation profile derangement and their effect on the outcome of head injury patients. We done a prospective study on 100 patients in Department of Neurosurgery, SMS Medical College, Jaipur, between June 21 to September 22. We include all the patients of age group of 1 to 70 years, and we exclude patients present with the other associated injuries like blunt trauma, abdomen, chest injury, and other orthopedics injury. And we exclude the patient associated with the other chronic diseases like hypertension, diabetes, and pre-existing coagulopathy, taking anticoagulant or drug affecting the lab testing, and chronic alcoholic patients. All the patients are divided into 2 groups based on the GCS. In group 1, we include the patient having moderate head injury, and group 2, we include the patient having severe head injury, GCS less than 9. After initial resuscitation and management, samples are taken for the CBC, prothrombin, partial thromboplastin time, and D-dimer and fibrinogen. Coagulopathy was defined as a platelet count less than 1 lakh and prothrombin time more than 15 seconds. RDIC score is more than 4, and outcome were defined by Glasgow outcome scheme. So in our study, we found 46 patients having moderate head injury and 54 patients having severe head injury, and total stay and ICU stay is more in patient who presented with the coagulopathy as compared to patient who having no coagulopathy. In similar severe head injury, we also found that patient who having coagulopathy having more total stay, ICU stay, and days are also more in patient who having coagulopathy as compared to patient who having no coagulopathy. Then we compare the patient who having coagulopathy without coagulopathy. So the platelets count were significantly higher as compared to patient who having coagulopathy, and prothrombin time and partial thromboplastin times are higher in patient who having coagulopathy. Then we compare the patient who are discharged and who are patient expired. So we found that platelets counts are lower in patient who are expired, and DIC score, prothrombin time, and partial thromboplastin times are higher in patient who are expired as compared to the discharged patient. So there we found there is no significant difference in hemoglobin, fibrinogen, and D-dimer between the patient with and without coagulopathy. Platelet counts were significantly lower in patient with coagulopathy, and prothrombin time and partial thromboplastin time were significantly higher in patient with coagulopathy, and there is no significant difference in the fibrinogen and D-dimer in expired and discharged patients, and the platelet count was significantly higher in discharged patients, and DIC score, prothrombin time and partial thromboplastin time were significantly lower in discharged patients. Present study shows male predominance with traumatic brain injury. Similar results reported by the Tawing et al. In 2009, and mortality rate was 39% in our study, which was at par with Afnorsa et al. In 2007 and Grutter et al. In 2011, and coagulopathy was developed in 49% in concurrence with Afnorsa et al. And mean platelet count in severe head injury group patient was lower than in the moderate head injury patients in our study. This was supported by Engstrom et al. In 2000, and mean prothrombin time in severe head injury group was higher in expired patient than discharged patients. Checker et al. In 2009 reported similar finding in their study. And mean D-dimer value was higher in patient with severe head injury, concurrence with the study by Q et al. In 2007, and severity of head injury. This is less than at affect effaced vessel system on CT scan, and HB hemoglobin level less than 10 strongly predict the development of coagulopathy. DIC score is statistically significant for predicting mortality rate, and presence of coagulopathy was related to the fatal outcome, and we emphasize the importance of early diagnosis of coagulation abnormality and taken action for correcting it. So the traumatic brain injury is complicated by the coagulopathy, and mortality of patient with moderate or severe traumatic brain injury can be predicted with the presence of coagulopathy and severity of head injury. And early diagnosis and prompt management can make remarkable improvement in the survival rates.
Yeah, hi, thanks very much, Dr. Joshi, for such a good presentation. So could I just ask you 2 points? One is, oh yeah, I should speak loudly, yeah. We are talking about differences in their coagulation profile. How have you calculated ISS score and like their physiological status by something like Apache score at the time of admission? Because the magnitude of other injuries and also if there is any hemorrhage, it would really make a lot of impact on it. That is one. And especially within first 6 hours of polytrauma, if the coagulation profile is maintained within the said ranges, let's say something like 40 to 60% of the target, they would really do well. So what has been done to maintain that coagulation profile within 6 hours? Sorry, too many questions in one.
Sir, we didn't calculate any other scores. We just assessing the Glasgow comma score, and there are other many factors which leads to coagulopathy, but we just this is just a prospective study, and we see only the impact on the mortality of the derangement on coagulopathy.
May I ask you something? Did you study, for example, the effect of any surgery of this patient? I mean, some of these patients have been evacuated, for example. I don't know, I mean, in this population, if there was any effect of surgery on the coagulation profile. And then if you use in your clinical practice any other instrument to study coagulation function, for example, thromboelastography or any other things, or only you measured the lab results?
Sorry, ma'am.
No, I said if you have studied coagulation only with the lab results that you showed, or if you use in the clinical practice other instrument to study coagulation, for example, thromboelastography.
No, we just
No?
no.
And if there was any effect of surgery, this patient have been operated or not?
No, we done
Or-
standard management. Either if patient having required surgery, then we do surgery also. But we just assessing Glasgow outcome scale at the end, having patient with coagulopathy and without coagulopathy. Management is according to the protocol. If they needed surgery, we do surgery, and if they require conservative management, then we do conservative management.
Okay, thank you.
Yeah, the next one, yeah, this is working now. The next presenter is Dr. Diksha Patel. Are you there? Yeah. Okay, and you're going to talk about therapeutic potential of intermittent theta burst stimulation on motor and sensory functional recovery to incomplete spinal cord injury patients.
So good morning to all. Myself Diksha Patel. I am presenting the effect of intermittent theta burst stimulation on recovery of motor and sensory function in complete spinal cord injury patient. So as we know, spinal cord injury is associated with trauma and non-traumatic cause that lead to sensory and motor damage. Approx 1.5 million people living with the spinal cord injury, and approx 20,000 cases added per year of the spinal cord injury in India alone. And the most common causes are the road traffic accident and fall from height. The most common pattern is ACI in those patients. The challenges with these spinal cord injury patients are the sensory motor dysfunction, autonomic dysfunction, chronic pain and pressure ulcers.
The therapeutic management of a spinal cord injury which is currently present are the conventional method, which are the surgical to stabilize the spine, and pharmacological and rehabilitation for the locomotor recovery, to gain some locomotor recovery. And the novel approaches which is still under trial are the stem cell therapy, nanoparticle and neuromodulation, which could be electrical stimulation, direct current electrical stimulation, transcutaneous electrical stimulation, and the transcranial magnetic stimulation. So I will talk about the transcranial magnetic stimulation. Transcranial, the proposed mechanism for transcranial magnetic stimulation is when we stimulate with the coil, the neurotransmitter release is there, which will cause the depolarization causes the local neurotransmitter release, which produce an action potential will descend down through the corticospinal pathway and can be recorded from the muscle in the form of these MEPs. And also because of the stimulation, the depolarization of pyramidal neuron also causes the neurotransmitter release in the deeper area, say limbic system and DLPFC, which also associated with the emotional and the psychiatric condition like the depression, anxiety and other things. So we are currently stimulating the primary motor cortex, which is associated with the leg area, and so these effects, the neurotransmitter release, the depolarization and deeper area stimulation associated with the increased cortical excitability, and in the neurotransmitter causes the long-term plasticity. So in our studies design, we have included the patient with ASIA-A aged between 18 to 60 years. We have 3 groups: placebo, spinal cord injury with RTMS, and spinal cord injury with intermittent theta burst stimulation. So repetitive transcranial magnetic stimulation and intermittent theta burst stimulation are the different paradigm of transcranial magnetic stimulation. In RTMS we have 20 Hz frequency for 20 minutes and ITBS for 50 Hz frequency for 3 minutes over the motor cortex with the help of figure of 8 coil. This is the study design. On day 0, we screen the patient, take the informed consent and all the other questionnaire and the electrophysiological recording. Then from day 1 to day 5, we give the ITBS or RTMS session, 2 sessions per day for consecutive 5 days. And at the end of the session, we also recorded the electrophysiological and behavioral parameter. So these are the represented video of few patients from our study. So the first one, the patient came pre-therapy, the patient came on stretcher because these all are the ASIA-A patient, and after 5 days of therapy, he is able to sit independently without any help. In the second, for the second patient, she is able to walk with the help of walker, and in the third patient, the pre-walking index for all these patients are 0. And she is able to walk with walker and the caliper intact. So the result, so all the patient, pre-intervention, the patient are ASIA-A, and in the interventional group, the score changes from B and C. The spinal cord independence measure, which include the self-care domain, respiration domain, and the mobility domain. So self-care include the grooming behavior, their feeding behavior and the bathing behavior. So the self-care, in the self-care domain, the score increase in the interventional group, and the also the mobility. Mobility is wheelchair to bed, bed to wheelchair, and wheelchair to that car. It is also increased in the interventional group, and whereas placebo group there is no mobility. But the respiration was okay in those patients, and the sphincter management is not like there is no progress in the sphincter after the intervention. The pain has also decreased, and also anxiety and depression also decrease in the interventional group, which leads to better, the improvement in locomotor function, decrease in pain, anxiety, depression lead to better quality of life in SCI survivor. Coming to the electrophysiological data, so motor threshold represent the threshold intensity at which we can generate any action potential in the muscle. So the motor threshold has decreased in the interventional group, and the latency is representative of the integrity of CS tract is also decreased in the interventional group. Here you can see delta change, which is 40 to 50% decrease in motor threshold and 20% decrease in the latency, which shows that there is increased neuronal membrane excitability and integrity of the tract. Then the cortical silent periods is the intracortical inhibition produced by GABA B, which is an inhibitory neurotransmitter, which is also decreased by 50% in the interventional group, which shows that there is a decrease in GABA inhibition and the increase in cortical excitability. Then coming to the recruitment, So as we increase the intensity, stimulation intensity, the amplitude has also increased. So it goes up to 0.1 millivolt in the placebo group, but in the interventional group, it bounces up to 2 millivolt, which shows that there is a more number of new motor neuron recruitment and motor unit formation in the patient after the interventional group. So coming to the discussion, without any therapy, there is a physiological process of the body, so the neuronal sprouting is there, but the synaptic transmission, as I say, the neuron transmitter has decreased, and which, because there is lack of the signal to the muscle, so muscle atrophy is there, and we can record a decreased motor evoked potential. But in the, which leads to the paraplegic condition only, but after the stimulation there is more neuronal sprouting, axonal growth, and number of neurotransmitter has also increased, as I told in the introduction. So there is no muscle atrophy, and the motor evoked potential is greater, which can lead to the improvement in locomotor function in the SCI survivor. So from this I can conclude that intermittent theta bus stimulation could be a beneficial therapy for the locomotor recovery and also the psychiatric condition in the SCI patient. Thank you. Any questions?
Yeah, many thanks, Dr. Diksha Patel. I enjoyed listening to your presentation. My question is really very simple. Not that I am challenging, but I am just very inquisitive about finding out how did your team decide the sample size of 5 in each group?
No,
Is
we
it
haven't decided. It's a preliminary study. We will include more patients.
Okay.
It's been 6 months only to
Yeah.
start this
So
study.
just one suggestion, that if you are really doing a pilot study, if the number is something like 30, 35, then you may expect it to be much more reliable. You can expect it to be in normal distribution.
Sure.
That is one. And second is, I never knew that one could evoke potentials in neurons through magnetic fields moving there. Because of course it has to be electrical trigger, but if a magnet has to be trigger, it has to be a coil, either coil moving or magnet moving. So how did you trigger those potentials
So
there?
sir, we are using the figure of 8, which is suitable for the brain, head size, and also the magnetic stimulation. It is based on the Faraday law of induction, electromagnetic stimulation, which says that if magnetic stimulation is applied in a closed loop, it will produce some eddy currents, which will then generate the action potential.
Very clever.
Quick question, please. I'm a little confused. You're doing this immediately after the injury on day 1 or day 2 for 5 days only at 3 and 20?
Not immediately after injury, once the suture get removed, so we are including patient within the 1 month of injury.
1 month
Once
of
the
injury, thanks.
spine is stabilized.
Okay,
then
because that's where sprouting will come.
Yeah.
Thank you.
Thank you. Any other question?
Thank you. Thank you.
Thank you.
Thank you.
So we call now Dr. Varun Kullar. He will talk on the effect of intracranial pressure monitoring on mortality in severe traumatic brain injury. Please.
Good morning. I'm Dr. Varun. I'm a senior resident. I'll be talking about effect of intracranial pressure monitoring on mortality in severe traumatic brain injury. So it's expected that in every year around 1.6 million people have traumatic brain injury in India, and around 200,000 people lose their life. And 1 million of them will require therapy for some or the other morbidity associated with it. Worldwide, traumatic brain injury is one of the largest. Disability adjusted life year lost to TBI is the largest. It's also a silent epidemic. Traumatic brain injury can also be its primary injury, which causes raised ICP leading to secondary insult. Both the degree and duration of raised ICP correlate with poor outcome. So ICP is measured to see the extent of injury, to guide the ICP guided therapy. It's also measured to calculate CPP and give CPP guided therapy. So a number of studies have been done in this regard, and the results of these studies have been conflicting to each other regarding the benefit of ICP monitoring in TBI. That's why we wanted to conduct a study to see the effect of intracranial pressure monitoring on mortality in severe traumatic brain injury. we did a prospective randomized comparative study. Randomization was computer generated. The duration was around 1.5 years. The sample size in this study was 72 patients were enrolled. They were randomized and 37 out of them underwent ICP monitoring, and the rest 35 were in the control limb without ICP monitoring. So inclusion criteria was all patients with severe traumatic brain injury, GCS less than 8. Exclusion criteria, we excluded pediatric population, pregnancy, with other abbreviated injury score in other systems more than 2, penetrating TBI, brain dead patients were also excluded. We, for all the 37 patients, we used a Codman microsensor intraparenchymal catheter, standard procedure by making a right-sided frontal burr and with a twist drill, placing in the parenchyma just below the dura, and doing the CT to confirm the position and measuring the ICP. So out of the 72, like I said, 37 in the case limb and 35 in the control limb. We matched both the groups in respect to age. Age groupings, both the groups were comparable in terms of mean age and age groupings, 18 to 40, 40 to 60, and more than 60. Gender distribution between both the groups was also matched, and both the groups were comparable in terms of gender distribution. Both the groups had male preponderance with around 80% males in one group and 83 in the other group. The most common, both the groups were also matched in terms of mode of injury. RTA being the most common mode of injury in young males, in young people less than 40 years, whereas as the age increases, the number of falls, the percentage taken by falls takes higher. Groups were also matched in terms of comorbidities. There was no significant difference between both the groups in terms of comorbidities. We also matched the groups in terms of GCS. The mean GCS in ICP monitored group was 6, whereas the mean GCS in ICP not monitored was 6, and in ICP monitored was 7. GCS was further divided into 2 groups, 3 to 6 and 3 to 5 and 6 to 8. We matched both the groups in control and case groups, and there was no statistical significance. Most common CT finding was contusion in both the groups, around 48%. Followed by an acute subdural hemorrhage around 20% and 21%. So again, groups were matched. So after matching the group, we did the results. So the overall in-hospital mortality was 44%. There's 32 out of the 72 patients. In the ICP monitored group, it was 32%. And in the non-ICP monitored group, it was 57%. So there was a statistically significant difference between mortality in ICP monitoring versus non-ICP monitored group. Then we further went and did surgical intervention. Out of the 72 patients, 34 could not be managed by medical measures alone, so had to undergo surgery. Out of the ICP monitored group, 15 underwent surgery, and non-ICP monitored 19 underwent surgery. Although there are slightly more number of patients who undergo surgery in non-ICP monitored, but there was no statistic, it was not statistically significant. The mean ICU stay between the both groups were matched. The mean ICU stay in ICP monitoring was 11.1 plus, 12 plus minus 2.3 days, and in non-ICP monitored was 11.1 plus minus 3.6 days. There was no statistical significance there. And similarly, hospital stay, the total hospital stay was around 18 days in non-ICP monitored and 19 days in ICP monitored, and again, it was not statistically significant. We went and did a multivariate analysis also, which shows that ICP monitoring is an independent factor for mortality. The adjusted odds ratio was 4.4, which was significant. So patients without ICP monitoring are 4.4 times likely to expire with, compared to the patients with ICP monitoring. So coming to discussion part, BTF guidelines support ICP monitoring in severe traumatic brain injury with patients with post-resuscitation GCS of 3 to 8 with an abnormal CT scan. There is a level 2 recommendation for that. And for patients with no identifiable lesion on a CT, so if it's a unilateral bilateral posturing or age more than 40 or hypotension, there's a level 3 recommendation for ICP monitoring there. Raised ICP is the leading cause of mortality within 48 hours after trauma. Early detection of raised ICP can lead to early management, be it medical or surgical. In 2015, Agarwal did a study in India which showed there was a significant decrease in hospital death in ICP monitored group. Li Sheng in 2016, this is a meta-analysis of 16 different studies. They also came to the conclusion that there is reduced 2-week and 6 months mortality with ICP monitoring. Our study also showed similar results. So effect on ICU or hospital stay. Some studies have come to conclusion that there is a significantly longer ICU or hospital stay in ICP monitoring. Telving, Haddad, Ellis all came to this conclusion. The postulate was possibly due to heavy sedation, prolonged ventilation to reduce ICP, but in our study we did not find any statistical significance there. So we come to a conclusion that guidelines do support the use of ICP monitoring. There is significant reduction in mortality with ICP monitoring in our study. It does not increase mean hospital or ICU stay, but there are more studies which are needed to validate these findings. The limitations was the sample size. Thank you.
My friend, unfortunately, I think your time has run out,
Okay.
so we're not able to have a discussion. I'll give you 2 comments, though.
Yeah.
One, your objectives need to change, because you said the effect of ICP monitoring on mortality. I don't think the monitoring caused the mortality, so that's what it came across. Number 2, you made a comment about the BTF guidelines. BTF guidelines may or may not apply to the motherland, so you have Indian-specific guidelines. Look at those. Thank you.
Thank you.
Appreciate it, Ron.
Yeah, thank you very much. Now the next presenter is Dr. Vinayak Dhage. Yeah.
She gave to her.
Yes. Oh, you have changed the order. Okay.
She's in control.
Not me, not me. But so the order has been changed. We call Dr. Manoj Kumar, a prospective study of novel therapeutic target IL-6, TNF-alpha, and interferon gamma as predictive biomarkers for the development of post-traumatic epilepsy. Thank you. Manoj, sorry.
Good morning, everyone. Myself, Dr. Manoj Agrawal, going to present a prospective study of novel therapeutic targets, interleukin-6, tumor necrosis factor alpha, and interferon gamma as a predictive biomarkers for the development of the post-traumatic epilepsy. Unprovoked seizure after 1 week after traumatic brain injury classified as a post-traumatic epilepsy. Post-traumatic epilepsy constitutes 20% of the symptomatic epilepsy in general population. The risk factor being severe head injury, certain type of injury, and post-traumatic seizures. About 33% of patients with a post-traumatic epilepsy are resistant to the anti-epileptic drugs. So need to develop a novel therapeutic target based on the molecular mechanisms. Some abnormal cytokine expression and immune system expressions are possible causes of this post-traumatic epilepsy. So cytokines causes regional hyperexcitability and the subsequent seizure. Simperidol showed blocking interleukin-1 activity as a potential anti-epileptogenic effect. So mechanism of epileptogenesis is possibly because of phosphorylation of the receptor at neuronal cell membranes, receptor modulation causing cytokinin to act as a neurotransmitters, damage GABAergic neurons in hippocampus leading to decrease in synaptic inhibition, inhibition of uptake of excitatory neurotransmitters like glutamate, and this activation of the NMD receptor which increase the intracellular calcium leading to the hyperexcitability. Why we use these parameters, like interleukin-6 is not detectable in the healthy CNS, binds to the interleukin-6 receptor and GP130 on the target cells, increase sensitivity to the glutaminergic agonist, induce seizures, reduce NMDA medicated neurotoxicity, increase level in the temporal lobe epilepsy. TNF-alpha is a dichotomous role in the neuroinflammation, binds to 2 different receptors in a dose-dependent manner. One is seizure activity through the P55 pathway, at a lower concentration, act as a pro-seizure, and the anticonvulsant through the P75 pathway. What in interferon gamma have protective effect on the hippocampal neurons. What is the objective of the study? To study the age and sex distribution of the post-traumatic epilepsy, to analyze the result of such cytokines levels in the blood, sample in terms of the serum levels at the time of injury, and their association with the development of the post-traumatic epilepsy. Relative sensitivity and the specificity of these cytokine markers and their role as a pro-seizures or the seizure protective mediator. So method to 254 patient with a head injury were admitted to our hospital in Atal Bihari Vajpayee Institute and the RML Hospital in New Delhi. Between the July 2017 to October 2018, of 41 patients who had a post-traumatic epilepsy, 6 had premorbid seizure. So we excluded the patients, and 35 patients included in the study, in which 32 were men and 3 were women. 30 adults from 28 men and 2 women as control individuals were enrolled. The control group consisted of the patient with a head injury without the post-traumatic epilepsy, fever, acute illness, or any other immune-mediated disorders. Patients with the post-traumatic epilepsy were diagnosed based on the clinical examination and EEG coupled with the neuroimaging findings. Both the study and control group were on anti-epileptic medications. The inclusive criteria: more than 18 years of age with the post-traumatic epilepsy, close type of traumatic brain injury only, not on any immune-mediated treatment or the immunoglobulin therapies, and no history of previous epilepsy or seizures. The exclusion criteria: polytrauma with other injuries such as fractures and liver injuries, other comorbidities such as the liver disease and malignancies, ongoing fever or history of the fever in the recent past, penetrating head injury, and pre-existing cranial disease such as the primary tumors or the brain abscess. There's a demography: the youngest patient in our study is 18 years and the oldest one is 75 years. The most common mechanism of injury included the automobile accident, which is 59.4%, 0.4, and the falls is 19.68. The incidence of the post-traumatic epilepsy in our patient is 14.1%. Of 41 patients who developed the post-traumatic epilepsy, 48.78% had a history of alcohol abuse, whereas 68 of the remaining 213 patients with head injury were alcoholics, which is statistically significant. The incidence of the post-traumatic epilepsy was greater in the patient with the severe head injury, with the GCS score is less than 8, which is 51.4%, whereas the other in whom post-traumatic epilepsy did not occur, only 28.6 had a GCS score of less than 8, which is a statistically significant again. Statistical analysis: the man-Whitney test is used. The p-value is less than 0.05 is statistically significant. After having removed the outliers and the ROC curve, 95 constants were determined, in which the interleukin-6, the level in the seizure group, 35 patients of having the mean value of the interleukin-6 is 121.36 picogram per ml with a standard deviation of 89.23. With the in non-seizure group, its mean value is 65.3 with the standard deviation of 74.75. With the interferon gamma in the seizure group, it's a very less, is 1.88 picogram, and non-seizure group is 1.10. In tumor necrosis factor alpha, its value 11.4 in the seizure group, and non-seizure group is 10.50 picogram per ml. As you can see, the interleukin-6 level was significantly higher in the seizure group than in the non-seizure group, with a p-value of 0.01, which is statistically significant. In the tumor necrosis factor alpha, the mean TNF alpha was 11.42 picogram per ml in the seizure group and the 10.58 in the non-seizure group, which is p-value is 0.3, which is not significant. And interferon gamma, the p-value is 0.09, which again is a non-significant. The ROC analysis of the interleukin-6, the graph above the 45 line and covers 69.6%, with the confidence interval is 95%. It indicates the interleukin-6 is a reliable biomarker for the post-traumatic epilepsy. Interleukin-6 level 31 picogram per ml could identify 80% of the patient population with a seizure, with a sensitivity, and had a specificity of 50% in table 5 and table 6. Of 43 patients, including case and control, who had interleukin-6 level in serum more than 31 picogram per ml, 28 actually had seizure. The positive predictive value for the interleukin-6 was 65.1% with a confidence in 95%. Thus, interleukin-6 level showed significant association with the seizure. TNF alpha showed no difference in the blood levels in the seizure and non-seizure group, nor was there any statistical significance. However, in the case of interferon gamma, the mean rank was higher in the seizure group, but this finding was not again significant. Came to this discussion part. The correlation between the neuroinflammation and the seizure activity is supported by the clinical evidence of the immune activation occurring in the epileptic foci of the brain tissue in the patient with the epilepsy. After seizure, the glial cells that are present in the vicinity of epileptic foci start producing inflammatory mediator, which again secrete some chemokines and which promote an inflammatory immune cascade. The mechanism by which cytokines causes seizure is not fully understood. Now, coming to interleukin-6 increase remarkably in CSF after traumatic brain injury, expressed by the astrocytes and myoglial. A meta-analysis of the 66 studies include 1,934 patient was performed by the Deveres et al., in which interleukin 6, 17 and CSF interleukin 1 beta was found to be increased in human epilepsy. An increased interleukin 6 level showed a statistically significant association with the post-traumatic epilepsy in our study. TNF-alpha is a dichomatous role with a bind in two dose-dependent manner with the TNF-R receptor 1 and 2. P55 initiates the apoptosis, whereas P75 mediates self-elimination. Many studies support the protective action of the TNF-alpha by its ability to modulate neurotropins production and prevent influx of calcium causing neuronal death. Seizure activity is mediated by the P55 pathway, whereas the anti-convulsive activity is through the P75 pathway. Some studies indicated in TNF as a concentrated dependent manner. At a low concentration, it had a pro-convulsive effect and high concentration.
Thank you, my friend. Unfortunately, your time is up. No time for discussion, but please, friends, whoever's presenting, listen to the bell. It's giving you a 2-minute warning to do discussion. Thank you so much, Manoj.
Thank you.
So next speaker is Dr. Saurav Jain. Significance of reduced CT imaging in mild to moderate traumatic brain injury. Please.
Good morning, everyone. My name is Dr. Saurav Jain, and I am going to speak about the significance of reduced CT imaging in mild to moderate traumatic brain injury. So, in introduction, traumatic brain injury is a common cause of morbidity and mortality worldwide. In India, it has been referred to as a silent epidemic, secondary to rapid urbanization, economic growth, and changes in the lifestyle that led to a tremendous increase in the incidence of traumatic brain injury. The principles of the management mainly centers around the prevention and mitigation of secondary brain injury. The CT scan of the head is the initial modality of choice to determine the type, extent, and severity of traumatic brain injury. The need for any neurosurgical intervention is based on the clinical status of the patient and the finding in the head CT scan. The role of initial CT scan of the head and of the unscheduled scan following deterioration is well established. However, no consensus yet exists regarding the need for follow-up routine head scan in minor cases on initial CT and in the absence of any neurological deterioration or new focal neurological signs. The aims and objective of the study is to determine the usefulness of the repeat head CT scan in identifying the radiological worsening of brain injury before deterioration that would lead to any change in the management strategy. So, it is a prospective study in which 250 patients admitted at the Department of Neurosurgery at SMS Medical College, Jaipur was included. Mainly the inclusion criteria was the mild to moderate brain injury with initial abnormal scan and presenting within 24 hours of injury. Patient who underwent immediate surgery after first abnormal scan or with a normal scan having linear skull fracture were primarily excluded. So this is a flow chart showing the patient management. Case selection was done based on the inclusion-exclusion criteria. The details was based on clinical feature examination findings and the CT scans were recorded. Patients were managed conservatively and were under close clinical monitoring. Repeat scan of the patient were done within 24 hours and at 48 hours of admission. If there is any radiological worsening noted in the first repeat scan and after clinical deterioration at any point in time. Both the initial and the repeat scan findings were recorded and compared as same, improved and worsened. The number of patients who required change in the management strategy were recorded and outcome of the patients were assessed at the time of discharge as per Glasgow Outcome Scale. So the results and observation of this study is most of the patients were male, having 74.4% of the patients. The most common age group was 21 to 30 years with mean age of 36.5 years. RT was the most common mode of injury in being 80.4%. At the time of admission, 70.8% of the patient had mild head injury, whereas 29.2% had moderate head injury. And at the time of first and second scan, the mild injury remained at the level of 76 and 73% respectively. So this graph shows that at the first at the admission, 80.4%, sorry, at the time of first repeat scan, 80.4% of the patient had same GCS. And 16.4% has an improvement in the GCS, whereas 2.8 deteriorated. And in the time of second scan, 9.4% of the patients deteriorated, which has a significant p-value of less than 0.05. So these tables show the variety of CT scan findings noted among the 250 patients at the time of admission in first scan, and at the time of second scan, only 179 patients were having the second scan. In this one, the cerebral edema significantly increased at the time of the first scan and the second scan, and there was a significant increase in midline shift. So the cerebral edema worsened in 51.2% of the patient at the time of first scan, and the midline shift worsened at 7.2% of the patient at the time of first scan, whereas midline shift worsened at the in the range of 15.1% at the time of second scan. Severity scoring was done in all the patients with these three scores: Master score, Rotterdam score, and Helsinki scoring. And the change in the CT severity scoring were noted at the time of first and second scan. So and it came out to be significantly that scoring has worsened in all the three groups. So management strategy: at admission, all the patients were managed routinely, and those patients who had increased signs of edema or worsening of the ICP were lead to this advanced medical management, and some of the patients went to surgical management. So at the time of first scan, 6.4% of the patients had surgical management, out of which 15 had the same GCS and the 1 deteriorated. And at the time of second scan, the 16.7% went to the surgical group. So, and the values are significant, less than the p-value is less than 0.05, which is significant. So GCS status in the surgical group: so at the time of first scan, mild cases were 11 number and moderate were 5, and the GCS were of the same grade. In 15 patients had the same grade, and worsening in the first only 1 patient. However, at the time of second scan, 13 patients had same GCS, and 17 had the worsening of the GCS. So outcome in the surgical group as per the Glasgow outcome scale, and the good recovery was there in 4.4% of the patients in the at the time of first scan, and at the time of second scan it was 1.6% of the patient. So overall, the Glasgow outcome scale at the time of discharge of these 250 patients, where good recovery noted as 67.6% of the patient, with having moderate disability in 16%, severe disability 9.6%, and person vegetative state in 6.8%. So on discussion: CT scan of the head is the initial choice of radiological investigation to evaluate patients with suspected head injury. The controversy arises in monitoring medically managed patients with routine repeat head scan when there is no deterioration neurologically. Because radiological deterioration precedes the neurological deterioration, it becomes important to monitor such patients with routine repeat head scan. Hence, an early intervention based on the repeat scan without neurological deterioration can prevent worsen outcome. So, in a study by Park et al., 37% of the patients underwent surgical intervention due to radiological progression without decline. Similarly, Thorson et al. Noted that 32 to 59% of the patients had no neurological decline before worsening of repeat scan. So, based on the analysis, altered GCS score, injury severity scale score, and Prism mass effect were individually associated with worsening of repeat scan. These studies were in the favor of repeating the scan. However, in the study by Varnam et al., 3 patients had undergone neurological intervention due to worsening of the CT without decline, and in the practice study by Sarafidhan et al., all patients experienced neurological decline before the repeat scan. So these are the found that the age more than 65 years, GCS score less than 15, and multiple hemorrhagic lesions were independently associated with the worst repeat scan. Similarly, Valmas et al. Reported that no patient underwent neurological intervention without clinical deterioration. So head CT scan accurately describes the injury anatomy, however, it's not a good functional assessment for injured brain. Although repeat scan seems rational in patients who cannot be followed clinically, but the role is less clear in patients with mild traumatic brain injury. CT scan for all admitted patients is not only costly but demands logistic for shifting critical often restless patients, besides entails risk of radiation exposure. It seems that routine head scan for every patient with injury in administrative practice that needs to be re-evaluated. Clearly, the cost of missing an injury progression can be devastating. Repeating a head scan in a patient with GCS score 15 at annual is likely unnecessary. However, a patient with more severe traumatic brain injury and larger SDH may still benefit from repeat imaging. So conclusion: the role of repeat scan in mild to moderate patients is often mild patients are often debatable. However, patients with mild to moderate head injury with multiple lesions present a midline shift differently requires a repeat scan to identify deterioration before clinical deterioration, so that appropriate management can be instituted to improve the outcome.
So time is over also for you, unfortunately. Any comment from? No. Okay. Thank you.
Thank you.
We may suggest to everyone to stay in time if you want to discuss with the auditorium. We go to next presentation. So let's see the changes. Should be Acuarte. What is Acuarte?
I'm sorry.
Akshay.
Which one are you talking about?
It's here.
Which one? Aparna.
Yeah.
Arpana.
So
Arpana.
Dr. Arpana Goswami.
Arpana, sorry.
Accurate should be, I guess. TBI triaging with a novel machine learning powered near-infrared spectroscopy based device. Thank you. Please be on time.
Good morning, everyone. I'm Dr. Arpana Goswami, Clinical Lead at Bioscan Research, and I am here to present the clinical validation studies of Cerebro, a machine learning powered NIRS device that objectively triages traumatic brain injury, a global epidemic. We have been nationally and internationally recognized for our innovation of deep tissue investigation with near-infrared spectroscopy. This will be the flow of my presentation today. Traumatic brain injury can be devastating, be it for individuals, for societies, or for nations at large. I'm sure many of you recognize these three individuals. Raman Lamba, a great cricketer of 90s, he had a tragic death due to the TBI on the field. Steve Wozniak, a co-founder of Apple, he is known to have retrograde amnesia post the TBI, and then he left Apple. Richard Ramirez, he is one of the most controversial person, and he is known to be most violent criminal in the history. He is known to have multiple episodes of head trauma during his childhood, and many researchers claim TBI to be one of the cause towards this behavior. So why is TBI a silent epidemic? Around 69 million people are known to suffer from TBI every year across the world. 25% of them have symptoms and are referred for further analysis and treatment at the right time. However, the rest 75% of them are known to undergo complex risk assessment, which delays the CT and hence the treatment, which ultimately leads to very low survival and recovery rate today. Now imagine, instead of this complex risk assessment, there is another method that objectively triages the patient, irrespective of any symptom or irrespective of any associated risk factors. This is the gap that we are trying to fill with the machine learning powered device. Cerebro is basically a point-of-care device that objectively detects intracranial hemorrhage of intracranial bleed more than 2 ml in volume and at a maximum distance of 3.5 centimeter from the surface of the brain. It is extremely safe to be used on infants and pregnant ladies, and it is very easy to use and learn device even by a paramedic staff. This is the basic technology behind the Cerebro.
Cerebro uses MRI spectroscopy or transmitted light shines light which travels through the brain, and that scattered light is captured. Obviously, that scattered light is analyzed by the computer unit for knowledge retention. As a result, it is displayed in real time. Cerebro.
The clinical validation studies included of 1 pilot and 3 pivotal studies at NIMHANS Bangalore, AIIMS Bhopal and Civil Hospital Ahmedabad. The principal investigator at NIMHANS Bangalore was Dr. Dhaval Shukla, head of neurosurgery. All these studies were prospective and observational studies with an objective to evaluate the efficacy of Cerebro against the gold standard CT scan. 642 subjects were enrolled in the study, of which 565 were included in the analysis. The exclusions mainly attributed to scalp lacerations or any prior neurosurgical procedures. The protocol mandated that each subject should be scanned with Cerebro within 60 minutes of the CT scan. Here is the scan locations for Cerebro on the left, and on the right is the result display screen, which is very easy to interpret. We did lobe-wise as well as subject-wise analysis, which resulted, this is the subject-wise analysis, and you can see a very high sensitivity, specificity and accuracy across all the pivotal studies. Coming on to Udin's index, a device is said to be reliable if the Udin's index is close to 1. Here you can see the Udin's index in the pivotal studies is around 0.81, and this was because the machine learning algorithm which we implemented in Cerebro. The clinical performance was also assessed according to the hematoma lobe location, where each lobe scanned with Cerebro was considered as an individual sample for analysis. You can see that the accuracy is consistently high across all the lobes. However, a lobe PPV was seen. This was due to a number of false positives. Now, false positives were seen basically due to two reasons. One was adjacent hemorrhagic lobe or due to cerebral edema. Adjacent hemorrhagic lobe basically means that if the subject had a hemorrhage in frontal lobe, it was sometimes also detected in the temporal lobe. Cerebral edema, although we considered it to be false positive in our study, it was taken positive by the investigators because it ultimately improves the clinical outcome. On the right side, we see the clinical performance according to the depth of ICH, and the device was able to detect all types of ICH, including contusions, with a sensitivity over 95%. Coming on to individual site analysis, for NIMHAN study, we had categorized our subjects based on the intracranial bleed volume of less than 2 ml and more than 2 ml. As you can see, NPV of 100% was seen when the intracranial bleed was more than 2 ml, and the other clinical parameters were also seen to be comparatively higher in this study group. For AIIMS Bhopal, we had categorized our participants according to the time from injury to cerebro scan, and a specificity of 100% was seen if the cerebro scan was done within 12 hours of injury. Coming on to Civil Ahmedabad, the participants were categorized based on their age, and here you can see PLR of 20 and NLR close to 0 was seen in all the study groups. Just to mention for reference, PLR over 10 and NLR close to 0 is considered to be accurate for any diagnostic test. We had 19 false negatives in our study. These false negatives were mostly due to the intracranial bleed being less than 2 ml, or the age of the injury being more than 72 hours, or there was some subarachnoid hemorrhage of unknown volume. Coming on to device limitations, for bilateral hematomas, they can be only detected if the volumetric difference between the two bleeds is greater than 2 ml. For any external active bleeding, the device has to be placed 0.5 centimeters away from the site of bleeding to perform the scan. Thank you.
Thank you so much. Is there any question, comment? Yes.
What were your false negative or false positive do? Which were the cases where you felt that Cerebro was not doing justice or you failed?
Actually, sir, like I said, false negatives, basically, I would not say that we failed, because Cerebro is able to detect if the bleed is more than 2 ml. So if the bleed is more than 2 ml, we did not get any false negatives. False positives we get mostly due to cerebral edema. Now for analysis, like I said over in that slide, for analysis we had to consider them as false positives because they were not intracranial hemorrhage. But one of our PIs, Dr. Jaimin Shah, spoke to them on the, while the first analysis was done, and he said that it's okay because cerebral edema can be devastating. So even if the NIRS device detects false cerebral edema, we know that some intervention needs to be done. So false positive and false negative, though we got it, but in a way it was a good one.
Thank you so much. Excuse me, we have to move on. Quick question. Are you representing a university or a company? I didn't get that.
So I am the clinical lead of the company which makes the device, and these three studies were investigator-initiated studies at these centers. So I am representing all these three studies on behalf of those investigators.
You're representing the company?
On behalf of the company and on behalf of the investigators.
Thank you. Go ahead. Thank you.
I think we have already time.
Thank you so much.
Thank you. Thank you. So the next, I think I'll leave it.
So next one is Dr. Vinayak Darji.
Vinayak.
Vinayak? No? Okay, so I think that last one should be Dr. Akshay Ganesh Kumar. Can CT finding at presentation predict persistent neurogenic bladder in subaxial cervical spine injury? Please.
Good morning. So this is an analysis of an ongoing study. We were trying to investigate whether CT findings at presentation can be used to predict urological outcomes after the spinal shock has settled in subaxial injuries. So introduction, subaxial injuries, as we know, there are multiple mobile elements in the subaxial cervical spine. It's a very frequent structure to be injured. It has a bimodal distribution between the very young and the elderly population. RTA is the is the usual modality of injury in the young and fall in the elderly. It can have devastating consequences. There were a few previous studies which were trying to create a prediction model for predicting the persistent urological outcomes after spinal cord injury. Most of them either focused on including all spinal injuries, not focusing on the subaxial cervical ones, or they focused on predicting the motor recovery after subaxial spine injury. So my hypotheses were, can an indigenous multivariate logistic regression model which incorporates the commonly available data at presentation be created, which then goes on to predict the urological outcomes after the spinal shock has settled in subaxial spine injuries? And second, will CT findings be non-inferior to MRI? This second question was posed because in low middle income countries, MRI is not usually, can sometimes not be available. So usually the patient only has a CT scan and we operate or we take decisions based on that, or even prognosticate based on that. So again, these were the objectives pertaining to the hypothesis. So we tried to develop an indigenous model and then we compared the predictive power of CT and MRI based scoring systems. This is an ongoing study, a disclaimer. The inclusion criteria were all patients with isolated subaxial spine injuries without any other spinal injuries or even girdle injuries, because pelvic girdle injuries, pelvic girdle fractures can have urological manifestations. Age was taken between 18 to 65 years. The reason being is sometimes the timing of MRI or CT gets delayed in the very young or the very old because of frailty issues. The data that was collected was the Asia motor score at presentation, not the Asia impairment scale. CT cervical spine findings were graded as per both the AO classification and the SLICS classification for the radiological findings. The MRI findings were classified in two ways. The levels of cord signal change was included, as well as the basic brain and spine injury center classification was used. Urological outcomes were seen after 3 months of injury, so that the spinal shock settles, and they were either telephonically obtained through the International Prostate Symptom Score IPSS for LUTS or through urodynamic studies. Both operated and non-operated patients were included. Currently, at this analysis, complete data for 25 patients is available. The patients who were self-voiding or on intermittent catheterization were followed using IPSS, and the patients requiring in situ Foley's were followed using urodynamics. So these were the scales. They are all published and validated scales which were used. So the variables were classified as such. AMS was taken from 0 to 100. AO had 3 categories, A, B, C. We could not delve into the subcategories because of the lower number of patients, so that decreases the power. SLICS was taken with 6 categories. MRI cord signal changes as per the levels of signal change. Basic was taken to have 5 categories as per the original paper. IPSS score more than or equal to 3 defined LUTS, and there are standard UDS cutoff criteria diagnosing LUTS in cervical spine injury. 10 patients had persistent urological outcome after 3 months, and 14 of them underwent UDS. Remaining 15 patients were on CIC or were self-voiding. IPSS was used. These are the summary statistics. So coming on to the analysis, in univariate analysis, it was found that Asia motor score, the motor score was the best predictor of urological outcomes, motor score at presentation, followed by the basic grading for MRI had the second most predictive power for urological outcomes, and SLICS was the third. Interestingly, because AO, we could not delve into the subcategories, and AO was having only 3 categories, it didn't have much predictive power, and MRI levels were found out to have very low specificity, due to which they could not predict the outcomes well. This is the ROC curve. The red line is showing the Asia motor score, and followed by basic and SLICs, whereas the yellow line shows the MRI levels and AO classification. These 3 variables, which are significant on univariate analysis, were used to create a multivariate regression model. The area under the curve, taking cutoff as more than 0.5, the prediction cutoff was 90%, almost 0.9, with a sensitivity of 94% and specificity of 79%, and it had significant prediction for urological outcomes. Coming on to discussion, for the sake of brevity I have kept this short. Coming on to discussion, the grading of CT findings as per SLICs could better predict outcome as compared to AO, because the subcategories we couldn't delve into. MRI grading as per basic was better than the levels of cord contusion, because basic delves into even the horizontal localization of cord contusion. CT and MRI had comparable sensitivity, but CT had inferior specificity. This could be because of Skivora, finding which we could see. AMS was the best predictor, so the clinical findings at presentation. And our model comparing basic, incorporating basic SLICs and AMS grading can predict with good sensitivity and specificity for now. This is an interim analysis. Thank you.
Yeah, I really enjoyed listening to you. I have quite a lot of interest in statistics as well. So could you tell me, you know, if you use the same instrument, same multivariate and logistic analysis, if you include the data in a population where the incidence of this clinical problem is much lesser, means those who come with milder or moderate injury, with milder injury, do you think the likelihood ratio would be different? Or in other words, whether the sensitivity and specificity would it be different?
Yes, sir. Because the prevalence of our outcome reduces in the hypothesized population put forth, our sensitivity should be lower, sir. Because the outcome which we want to predict is not happening as frequently.
So the next question correlated to that is that then why are we not really doing LR ratios rather than talking about sensitivity and specificity, which may over project the value of a test? Not that you are doing it deliberately, but it may happen.
Yes, sir. The reason for that is this was an interim analysis. We are working on it.
Small clarification now. Can I ask a question?
Sure, please.
Just to simplify whatever you said,
yes,
you had CT, you had MRI, and you had clinical evaluation.
Yes.
And you found that the clinical evaluation was most predictive.
The motor score,
urologic
yes,
outcome.
yes.
So what about the sensory and the motor outcome correlation?
Our primary outcome focused on the urological one, sir.
No, didn't you not include motor and sensory as a comparative?
Not in this interim analysis. We haven't, sir. We are focused only on the prognostication for urological outcomes.
Can you tell me how could you correlate the urological outcome with the?
Sir, the urological outcome was defined as either a patient having an IPSS score of more than 3, or if they were on in situ catheterization using urodynamic study cutoffs. And in those patients, we saw what was their clinical findings at presentation, what were their CT findings at presentation, and what was their MRI.
We'll discuss later.
Yeah.
Thank you so much. So, last presentation, Dr. Sharin Varma. Macrobiological profile and the resistance pattern of pathogens in neurosurgical patients from a trauma center in New Delhi. Thank you.
Good morning to all. So today I'll be presenting the microbiological profile and resistance of pathogens in neurosurgical patients from a trauma center, New Delhi. So as we all know, neurosurgical patients are at an increased risk for healthcare associated infections. Individuals with traumatic brain injury were found to be 12 times more likely to die of septicemia, 4 times more likely to die of pneumonia, and about 3 times more likely to die of other respiratory conditions. Sepsis has been found to affect between 10 to 41% of patients with traumatic brain injury. Coming on to the methodology, so this was a retrospective study from Trauma Center AIIMS for a period of 10 years from 2012 to 21. The inclusion criteria were all samples from symptomatic neurosurgical patients, including both wards and ICUs. The samples were processed according to the routine microbiological procedures. Blood culture was done by BacT-Alert, the respiratory and urine was done by semi-quantitative analysis, and the CSF was also done according to the routine procedure. The isolate was identified by Vitek 2 and Malditov systems, and the antimicrobial susceptibility testing was performed by Vitek and Kirby-Boyd disk diffusion according to the CLSI standards. Coming on to the results, in a total span of 10 years, we received total samples of 48,474, out of which 21%, that is 10,134 patients, had significant growth, which means pure isolates. The most common amongst these pure isolates were gram negatives, that is 88.5%, followed by gram positives, 11.5%. The most common age group that had the growth of pure isolates were young adults in the age group of 19 to 40 years, and the most common growth of pure isolates were found in males as compared to females. If you look at the pie chart, the most common sample that we received were the respiratory samples, followed by blood and pus. Now, as I've already mentioned, in our study of 10 years, we found that gram negatives were most common than gram positives. Amongst the gram negatives, the most common pathogen was Acinetobacter baumannii, followed by Klebsiella pneumoniae and Pseudomonas aeruginosa. And amongst the gram positives, the most common was Staphylococcus aureus, followed by Enterococcus faecium. Now we took out the percentage resistance of some of the drugs to the gram negatives, and what we can see is that if you look across the columns, the first column, Acinetobacter baumannii, the percentage resistance is more than 90% for most of the drugs. Whereas if you see Pseudomonas aeruginosa, it is towards the lower side, and all the other gram negatives, that is E. coli, Kleb and Proteus, have an intermediate range. If you see across the row, if you see the weighted average of one particular drug across all the organisms, we can see that it is more than 80% for all of the drugs except for carbapenems and amikacin. Now the distribution of the gram positives and gram negatives by sample type was almost uniform across all the samples except for urine, where instead of Staphylococcus aureus we have Enterococcus faecium for gram positives, and for gram negatives instead of Acinetobacter baumannii, in the urine sample we have Kleb and E. coli as the most common ones. Across the age group, if we see the pattern of organisms across the age group, as I've already mentioned, gram negatives are most common and Acineto was most common. But what is interesting is that in the age group of 0 to 3 years, the pattern has changed, and instead of Acinetobacter baumannii, the most common pathogens found were Klebsiella pneumoniae and Pseudomonas aeruginosa. Across the gender, both the pathogen profile was almost similar in both males and females. So the antimicrobial susceptibility showed a high level of methicillin-resistant Staphylococcus aureus, that is 72%. The weighted average of drug resistance profile across all gram positives was greater than 50% for most of the fluoroquinolones, gentamicin, erythromycin and ampicillin. Now this was the bacterial profile. If we come on to the fungal profile, it was much less in these 10-year time period. That is, only 32 patients had candidemia, of which 6 were Candida albicans and the rest were non-albicans candidans. So amongst the non-albican Candida, the most common, which was accounting for 28.1% each, were Candida paractylosis and Candida tropicalis, and which was followed by Candida glabrata. A total of 6 neurosurgery patients had also infection with the dreaded Candida auris, 4 of which were isolated from blood samples and 2 from urine. So coming on to the discussion, the gram-negative pathogens were the main infectious cause in our study, and similar findings have also been found in other countries, Southeast Asian countries like China, where there was a predominance of gram-negative over gram-positives. Secondly, the overall resistance of staph to fluoroquinolones was much higher for ciprofloxacin as compared to levofloxacin, and this was statistically significant with a p-value of 0. Though our study showed a majority of non-albican Candida, but many long-term studies also show that Candida albicans predominates in such kind of patients. So the conclusion is the present study finds a very high prevalence of MDR Acinetobacter baumannii causing the healthcare associated infections. And preventive bundles for respiratory tract infection must be institutionalized to lower respiratory infections, since we have observed that the most common sample that we have received from symptomatic neurosurgery patients are respiratory samples. And hospitals must pay careful attention to infection control practices and active surveillance for notable control over these life-threatening organisms. Thank you.
Any questions from the audience?
Yeah. Yeah, I have got really, I've got comment as well as a question to you. Actually, I must admit that I'm really quite scared to see such a magnitude of drug resistance, antibiotic resistance in these patients. I'm not trying to be over smart here because I'm not in the thick and thin of it. But every time effective water on is, every time you go there, is there in foreign body, can I stop the antibiotics? We need to really keep doing it. Again, I'm not giving any lesson here. But all I'm trying to say is that we doctors and also the veterinary surgeons are responsible for so much of drug resistance. Again, I'm not pointing finger at it, I'm just only saying it towards me. What I'm trying to say is that do we have regular MRSA rate in your hospital, number one. Number two, what is the CDT rate? These two would be a very good parameter of saying are we overusing it or not. But it is beyond your control here, because by the time you come to the hospital, the patients come to the hospital, they will be on 2 or 3 antibiotics, second, third line anyway. So you and me cannot do much by the time the patient comes to a tertiary care center.
Sir, as far as MRSA is concerned, I have already mentioned we have a high MRSA rate in our hospital for 72% in spite of a good infection control. And CDT is carbapenem-based detection. What is CDT, sir?
CDT, Clostridium difficile toxin positive diarrhea.
No, sir, for that we don't have any detection.
May I ask you a question? Did you differentiate between colonization and infection? Because I mean, finding something positive does not mean that is an infection, depending on the quantification of the cultures.
Yes, ma'am, that's a very good question and a valid question. So most of the samples that we received are from symptomatic patients, first of all. And the microbiologist is in connection with the clinician, so we take history and everything to minimize the report or processing of a contamination. So, and also if we receive one sample from a same patient from the same site within a period of about 14 days and the same growth is there, we give it as one.
Yeah, does the microbiologist come and see the patient? Do they come and see the patients?
Yes, so we take as far as time permits, we go and take rounds along with the clinician.
Thank you. So we have to close the section. Thank you to everyone.
Thank you.
So that is the end of the day's play.
Because we have 2 minutes more per session.
Okay.
Are you staying back? I have to go.
I don't know.
We go back.
I think